sessions as we talk about cases. But really the focus this week is on foot and ankle. And I just want to focus on a couple of house rules before we really get our introductions going. Again, keep your mics on mute for those who aren't going to be, while our speakers are giving their lectures. But once we are able to get questions going, unmute, raise your hand, and chime in and join the chat. We'll be monitoring that as well. And full recordings will be available on a YouTube channel as well as on our websites. Just a reminder, where this session is put on by our orthopedic trauma and reconstruction faculty at Mac Ortho. I'm the director, but we have our entire faculty joining and contributing as we moderate each of the sessions. Tonight, we'll be joined by our foot and ankle group, which I help with the trauma, but our trauma as well as reconstruction and some of our elective procedures are run by these two individuals, Dr. Jamal Al-Asiri, who's also our CTU, Clinical Teaching Unit Director at the Hamilton General Hospital Level 1 Trauma Center, as well as Dr. Brad Petrosor, who is, many of you met last week, is really one of the founders of the strengths of our strong clinical and research program here at Mac Ortho, and we're lucky to have him and share his expertise on foot and ankle as we roll through our speakers here. And we really are joined by a great panel, and we have a great evening lined up tonight. We're going to be discussing some techniques around management of the syndesmosis, specifically with focus on some of the data coming out of some COTS trials. And that'll be run by Dr. Prism Schneider. Dr. Chad Coles will be sharing some information on percutaneous fixation of calcaneus fractures. And then Dr. Lisa Canada will be talking about the elderly ankle fracture, or less, maybe more. And then just as for those of you who haven't met some of our panelists, haven't had the pleasure of meeting some of our panelists, Dr. Prism Schneider will be sharing her knowledge and experience. Again, she comes from the University of Calgary, where she runs the trauma research program and is really a strength and a huge champion for COTS with many of our research trials going on there. Dr. Chad Coles joins us from Dalhousie in Halifax, where he focuses on orthopedic trauma and complex reconstruction. His training is his fellowship training is from the Harborview Trauma Center, and he is a heavy influence in COTS, as well as AO, is really one of the master educators we have in our Canadian Orthopedic Trauma Society. And Dr. Lisa Canada, speaking of master educators, we're lucky to have her join us. She's been so instrumental in many of the education and leadership initiatives at the AOS as well as the OTA. Lucky to say she's also a fellow graduate of our alma mater, Shock Trauma, and briefly worked at St. Louis University thereafter, and currently practices in Jacksonville, Florida, focusing on orthopedic trauma. So with that, I'm going to turn things over to Dr. Al-Asiri, as well as Dr. Petrosor, once he joins us to moderate the rest of the evening session. And I will stop sharing my screen, and maybe we can get Prism to start sharing hers.
There we go. Are you able to see my screen there?
Coming through great, Prism.
Okay, fantastic. So perhaps I'll just crack on, so we've got lots of time for discussion. Once again, thank you so much for the invitation. Really a pleasure to be here with such a fantastic panel, and I love seeing the numbers go up. So there are some disclosures that I would like to acknowledge, none of which really pertain to this particular talk. What I wanted to do is sort of try to summarize what we know, what we think we know, and what questions remain around syndesmotic injuries, and really sort of frame it in the setting of our recent COTS randomized controlled trial. And so some things we know about syndesmotic injuries, the syndesmosis in general. Intact ligament complex is certainly very critical for stabilizing distal tibiofibular joint. It's really important that our syndesmosis can actually accommodate normal physiologic motion, so widening of the mortise, external rotation of the fibula. This is very normal physiologic motion that is critically important for optimal function. We know that syndesmosis injuries are very common. In fact, up to a quarter of ankle fractures can have an associated injury to the syndesmosis. Malreductions, also unfortunately very common, and upwards of 50% in the literature, and certainly concerning numbers when we look very consistently at our malreduction rates. it's concerning because we also know that malreduction is really the critical thing when we talk about functional outcomes. So by obtaining an anatomic reduction, this is really where we can optimize our patient's functional outcome. And within 1.5 to 2 millimeters, malreduction can really reduce patient physiologic motion and therefore functional outcome. So a lot of this really spurred on the Canadian Orthopaedic Trauma Society to get together to really try to answer, can we do a better job of fixation around the syndesmosis? Traditionally, we were using rigid fixation across a joint. And so we really wanted to look into, should we actually be looking at dynamic stabilization of this dynamic joint? And so this was a paper that we published. It was an OTA highlight paper. And certainly this work could not have been done without the entirety of the COTS organization. So just to dive into the study a little bit, this was a multi-center randomized controlled trial. We had 103 consecutive patients, and they were 18 years of age or older. There were 11 participating sites, and our recruitment was actually quite quick. So it was a fairly short enrollment period. And these were patients that required operative fixation of AO-OTA 44C injuries. Randomization was done using an electronic online system, and patients were randomized to either open reduction and static fixation with 2 3.5 millimeter screws, or open reduction and flexible fixation with a single knotless tightrope construct. Our primary outcome measure was in fact malreduction, and this was based off a 3-month bilateral ankle CT scan. We did look at a number of secondary outcomes as well, including reoperation rate, adverse events, and a multitude of functional outcome measures that we'll go into in a little bit of detail. Our follow-up for this study was 12 months. And so I think it's really important that we discuss and define malreduction of the syndesmosis. There are some variations throughout the literature. And so for our particular study, we defined malreduction as 2 millimeters or more of translation of the fibula, or more than 10 degrees of mal on the CT scan, again, comparing contralateral uninjured side to the postoperative side for fibular translation, rotation, and then anterior middle and posterior syndesmosis distance, which I've illustrated over here on the right. So here's our consort diagram for this particular study. As mentioned, we had 108 patients from not significantly different, and otherwise these groups were very similar. So it's really important to kind of look at the exact surgical technique that we utilized in this study. So everyone began with fibular fixation, and at this point an external rotation stress view was performed. We defined, again, instability as lateral translation of the talus more than 2 millimeters, and that's where there was those few patients that had to be excluded at this point from the study. Open reduction was used in all cases, and that's important to note that we really focused on the anterior fibular border and how that lined up with the anterolateral tibial plafond. We did permit clamps or manual reduction in order to obtain that open reduction under direct visualization. And then patients were once again randomized to either 2 tricortical 3.5 millimeter screws or that single tightrope insertion. Care was taken to ensure that implants were parallel to the mortise and they were at least 1.5 centimeters proximal to the ankle joint. Interestingly, we did actually standardize tensioning of the tightrope, and this was using an ACL tensioning device. So we did standardize that. I know a number of us would cycle the ankle joint to ensure the creep was taken out of the system to ensure standardization of that tensioning of the dynamic stabilization device. So our results of this study, if we look at our fibular fracture with an associated syndesmotic injury, we did have a higher malreduction rate in the screw fixation group at 39%. Our reoperation rate, again, was much higher in the screw fixation group as well at 30%, and the majority of these were for screw removal. In the tightrope fixation group, the malreduction rate was improved at 15%, and this was statistically significantly improved, as well as the reoperation rate at only 4%. If we look at what type of malreductions occurred, it was interesting to see that in the screw fixation group, about 5 of these were actually because of a rotational malalignment, and 8 of them were actually pushing an anterior subluxation. If we look at the tightrope fixation, it was sort of a bit of an even distribution between rotational malalignment, anterior and posterior subluxations, but certainly a smaller number of overall malreductions in the tightrope fixation group. If we then focus on adverse events, in our screw fixation group, we did have a higher number of adverse events. 7 patients had reportable screw irritation that did require implant removal, and 2 had loss of reduction that required revision fixation. In the tightrope group, this adverse event rate was about 4%, and this included a loss of reduction that required revision, and unfortunately 1 deep infection where the knotless device in fact had several knots placed instead of having the sutures cut flush with the endo button itself, and resulting in a deep infection in this particular case. If we look at the functional outcome measures, we really do have to note that this study was powered for malreduction as our primary outcome measure. And when we did a priori sample size calculations, depending on which of these patient-reported outcome measures was used, our sample size ranged anywhere from about 200 or so to over 500. But it's worth sort of taking a look at what we learned from these functional outcomes. So I have the outcome measure on the left, sort of what it assessed. We tried to spread between general health, regional specific, and injury specific measures. And we did see some improvement over time in both groups, of course, notably, with very little difference between the 2 groups over time. The thing to note is the FADI score, or the foot and ankle disability instrument, and this did actually have a 10-point improvement with the tightrope fixation group, though not statistically significant. And then similarly, if we looked at activity-related scores, we actually found that the tightrope group had a significantly higher rating for daily activities at 3 months, and they actually returned to work and had increased work hours earlier on. Again, not powered for these outcome measures, but worth sort of mentioning the trend. So what do we know from this study? Well, malreduction rate was lower in the tightrope fixation group. Reoperation was higher in the screw fixation group. And there was a trend towards improved functional outcomes favoring tightrope fixation. So if we move on to what do we think we know? So we followed these patients for 12 months, and we make some assumptions at the functional outcome measure at 12 months about the actual reduction. There's some assumptions that, criticisms of a dynamic stabilization device loosening over time, for example, or what happens when screws break or are removed. And so we did follow some of these patients at 12 months with a repeat bilateral ankle CT scan. So we looked at 42 of these patients. 24 of them had been treated previously with screw fixation and 18 with tightrope. There were slightly more males in the screw fixation group, no significant difference in age between the 2 groups. And interestingly, if we look at the 3 and 12-month comparison between this is the anterior syndesmotic distance, for example, we have the tightrope fixation in red on the left, and you see very little change between the 3-month and the 12-month mark. So in this small cohort, we did not see stretching out of the dynamic stabilization device or any loss of reduction overall. In the screw fixation group, at this point, at 12 months, 88% of these patients had actually had their screws removed or they were broken. And you can see a significant increase actually in the diastasis and the anterior syndesmotic distance with the screw fixation group. So this is interesting. This leads us to think, well, what about static imaging of a dynamic joint? We've just talked about how important it is to potentially use dynamic stabilization of a joint. Well, how about imaging it appropriately as well? So conventional imaging is really limited by only assessing the syndesmosis in a static position. And quite often in our literature, there's no standardization of the ankle position. And we know that there's normal physiologic syndesmosis motion that occurs throughout a range of motion. And so another area that we're investigating is the use of 4D or dynamic CT to measure syndesmotic position change throughout an ankle range of motion. And I have to give credit to Dr. Murray Wong, who is a resident here at the University of Calgary and has just completed his master's in biomedical engineering in this area, because this is now allowing us to look at physiologic motion between these 2 constructs over time throughout a range of motion. So what do we see when we sort of look at these preliminary findings? And I don't want to steal Murray's thunder because he will be presenting this at both the COA and the OTA upcoming. But if I highlight here that we've got both maximal dorsiflexion and maximal plantar flexion as static images here, if we look at the uninjured ankles, you can see that as we move through a range of motion, there is motion in the syndesmosis, of course. The incisor area changes. And then if we look at what the effects are in the rigid fixation on the left, I apologize there, and flexible fixation on the right, we can see even visually that there's a recreation of more physiologic motion with a dynamic stabilizing construct. So still some things to be learned here. So I'd like to leave some discussion points here. What questions remain? So longer term functional outcomes, of course, still remain a question. Appropriately powered studies in order to address differences in functional outcome measures between these two types of fixation. How about planned screw removal that occurs much earlier that may both similarly avoid diastasis, but may avoid some of the reduction in motion that we're seeing with our dynamic CT results? Length and stable fibula fractures were not included in our study, and this still remains a challenging area. And posterior malleolus fixation is certainly becoming more of an important technique that we're learning about. And how does that impact our stabilization of the syndesmosis? How about deltoid ligament injury as well? And then I hope that I've highlighted optimal radiographic assessment is really important. We talk about comparing to the contralateral side, even intraoperatively. And I think we're learning more and more about the very important position of the foot and making sure that that's standardized between the injured and uninjured ankle. So thank you very much for allowing me to chat about this particular study and hopefully stimulating some discussion around syndesmotic injuries in general. Thanks very much.
Thanks, Brett. I would like actually to also thank Herman Johal, give me the opportunity to participate tonight. Great summary of the study. Great job. Reflect how cooperative Canadian group actually putting that study together. And actually, it's amazing me the last slide you put all the questions. I have a couple of questions here in my hand, and I said, wow, you put all the questions right now what I'm gonna ask. So great. We'll just leave opportunity for people who are attending here. We have 50 people here. If anyone want to jump in and ask a question.
I think, Jamal, maybe why don't we save questions for the end after all the speakers go, and we'll just keep discussion going.
Okay. So if we're going to go ahead with the discussion, so I think I'm going to move the speaker to Dr. Coles, who's going to talk to us about percutaneous fixation of calcaneus fracture.
Perfect. Thanks very much for the invitation to attend. Some of you fix a lot of calcaneus fractures. I see Dr. Buckley on the webinar tonight. Some of you may say, well, I never fix calcaneus fractures at all, but hopefully this will sway some of you towards at least feeling willing to fix some of these in your practice. So consider this: a 24-year-old woman has the fall from height, presents with this injury. Here's her CT scan. And just think about in your practice, you're on call tonight, this woman comes in. How would you treat this? I think certainly there's a lot of controversy about the role of open reduction internal fixation. Most studies have shown that really there's not much difference in the clinical outcomes in some of these fractures. And the biggest difference between the groups tends to be the incidence of complications. Certainly patients that do not have an operation have no risk of operative complications. So it goes without saying that the risk is going to be higher. But if you look at some of the randomized trials, most of them show no functional difference at 1 to 2 years. But as you follow them out longer, there may be some long-term benefit. These two meta-analyses both showed, again, increased risk of complications with surgery, but in the long-term results, better results as far as subtalar arthrosis, fewer problems with shoe wear, and better walking ability. So long-term, there may be some benefits. And the question I would pose is, what if you could have the benefits of surgical correction of the deformity without the risk of complications? And hopefully over the next 10 minutes, by the end of this, you'll be able to describe the rationale for the use of percutaneous fixation, to be able to recognize some of the surgical emergencies where this might apply to you when you're on call and seeing these patients that come in through the emergency department, and then hopefully feel able to safely start to use this technique in your surgical practice. I'll remind you the class of 8 will have some component of a tongue-type pattern to them, in contrast to the joint depression where the articular block that's depressed is separate from the tuberosity fragment. I'll also remind you the Sanders classification. This was from 1993, a CT classification. And really what we're going to be talking about tonight are the type 2 fractures where there's a single split into the posterior facet. The type Cs where the posterior facet is intact and the split is over adjacent to the sustentaculum. The type 2s where that posterior facet is split pretty much symmetrically in half. And then the type A's where it's an even more lateral fracture line. So just keep those 2 classifications in mind as we start looking at these cases. Percutaneous technique's not new. Most credit Essex Lopresti for the technique, but if you look back even further, back as far as 1935, Westhus described the technique. There was the Gassane spike. But what was different with this is it was a Steinman pin or a Schanz pin driven into the tongue fragment of the calcaneus, and then as you'll see here, incorporated into a plaster cast. Certainly some problems that can happen with that as far as pin tract infections and loss of reduction and certainly some of the downsides of stiffness associated with these articular injuries, but not much changed with the percutaneous technique until Tornetta described the use of this in 98. So this was a revisitation of the Essex Lopresti reduction initially described in those Sanders 2C fractures where the posterior facet is one intact fragment attached to this tongue segment. And then secondarily, another publication 2 years later in 2000, where they also incorporated a few patients where now the articular facet was split in 2. And this technique, a little bit different than what Essex Lopresti and Gassane and Westhus had described, is with this tongue fragment, using that same Schanz pin or some sort of a percutaneous implement in the tongue fragment to manipulate it into position. But now rather than incorporating that into a plaster cast, proceeding to use cannulated screws to achieve fixation. Subsequent authors have compared the results of percutaneous fixation with open fixation of fractures. This is a quasi-randomized study, so it was just by 2 different surgeons. But what they showed was really there was no difference in the reduction quality, fusion rate, or function at 2 years, but they did have a significant decrease in wound complications with this percutaneous technique. Similarly, 58 fractures here randomized to open reduction or 25 that were treated with closed reduction, and again, decreased wound problems, decreased deep infection rates. And then this meta-analysis, it incorporates over 700 patients, again showing no difference in reduction quality or functional outcome, but a significant benefit as far as operative time, if that's important, and a decreased rate of complications with a percutaneous technique. So for those of you who don't fix a lot of calcaneus fractures or wondering why this is important to you, these next 3 slides should really serve as a reminder. And it's because some of these fractures will present with skin at risk. And this is a time-sensitive condition. And if you're on call and these fractures come in, you may be obligated to manage them, even though you're not your local foot and ankle or calcaneus surgeon. Most of the problems come with the tongue-type fractures. In this study, that was only about 15%, but about 20% of those tongue fractures that present, so 1 in 5, will have that impending skin complication. And if you just put them in a bulky splint and send them to clinic in 2 weeks, when you take the splint down, unfortunately, you'll be looking at this. So when you see that x-ray and see that tongue pattern, you'd really need to be carefully assessing the posterior soft tissues, as some of these will be a surgical emergency. This larger study, over 600 fractures, their incidence of tongue-type fractures was closer to 50%, so 46, 47% of their fractures. And again, that same number, 1 in 5, will have posterior skin compromise. So again, think about these as a surgical emergency. And you may be, again, in a position where you need to be prepared to deal with them when you're on call. So with my practice, and I'll show you a bit about the technique that I've adopted, and hopefully you'll consider using in your practice. I think the best way to do this is to start simple. So for me, this started with simple two-part tongue-type fractures. So here's a typical case of a 34-year-old. Again, the typical mechanism of a fall from height. You can see here that there's articular depression. We look at the CT. Again, this is one of those 2C fractures. So the sustentaculum is separate from the posterior facet, but there's no real intra-articular involvement. So it's just one big articular fragment. We don't see a lot of comminution of the anterior process. So a relatively straightforward fracture pattern to start with. You can appreciate on the coronal and sagittal reformats that we've got a loss of height. So Bowler's angle is essentially 0. You can see that the articular facet is depressed down into the body of the calcaneus, and also that this fragment is significantly tilted in the coronal plane. And again, you could manage this non-operatively if the skin is not at risk, but in a 34-year-old, this is a fracture pattern where I think I can take this from a potentially operative fracture to one that I would never consider operating on with a fairly simple percutaneous technique and relatively low risk to the patient. For me, the setup's in the lateral position with the operative extremity up on a radiolucent extension. Bring the imager in from the foot of the bed. So this allows us to get both a lateral and an axial view. And the equipment is simply a 5mm Chance pin that's used as the tool to manipulate the tongue fragment. And then you need a small fragment set as well as some long 3.5mm screws, typically from the pelvic set, as often you're looking at 70 or 75mm screws for these fractures. Here's the setup. So again, on a radiolucent extension, I just use flannels for positioning. So ideally, you want the non-operative limb a little bit anterior, so it's out of the way of the imager. Here, the knee's flexed, and then you put enough flannels that the foot, the lateral border of the foot is essentially level to the horizon. The imager, again, comes in from the foot of the bed, so this allows us to get a lateral image in this position. And then by bringing the X-ray machine up underneath the drape on the table, extending the hip and flexing the knee, you can quite easily get a nice axial view to assess the articular reduction and position of your implants. With this setup, starting in the lateral position, the reduction sequence is as follows. So you want to first obtain a good quality image so that you can assess your starting position. And then with a small incision through the Achilles tendon, come in with a 3.5mm drill, come in on the top of the tuberosity. So you want to keep the tip of your drill bit and your Chance pin far enough away from the fracture site that when you go to manipulate the fragment, that doesn't fall into the fracture. Your trajectory is then headed for the anterior aspect and the inferior aspect of that posterior facet, so that as you apply that torque to the Chance pin, there's less risk of it cutting out of the bone. Once you have your Chance pin in place, here now I've got the Chance pin and the T-handle chuck held in my left hand. The palm of my right hand is on the dorsum of the foot, and you can see my thumb on the plantar aspect of the calcaneus. And this gives a 3-point sort of fulcrum to allow me to manipulate that tongue fragment back up into position. With that joystick, you can see now we're able to elevate that posterior facet back up out of the body of the calcaneus, back up into its resting position beneath the talus. And with it held in position now, you typically 2 longitudinally placed 3.5mm screws, again starting high on the tuberosity, just under the angle of Gaussian into that anterior process. I'll then typically run a screw from lateral to medial, headed over into the sustentaculum. So that's going to go underneath that posterior facet into the constant fragment. And then often a screw that comes down through the tuberosity into the plantar aspect of the calcaneus to neutralize the pull of the Achilles tendon. And this would be a fairly typical final construct for me. So 4 screws, about $40 worth of implants, 2 longitudinally placed, again, just underneath that posterior facet at the angle of Gaussian, a screw across from lateral to medial into the sustentaculum, and then a final screw to, again, neutralize the pull of the gastrocs. And then as you get comfortable with this technique, then you can start to challenge yourself a little bit and go from those where the articular facet is all one fragment to those where there's a more of a 2B or even a 2A fracture. Here's one where there's an actual fracture dislocation. So that 2A fragment is actually sitting lateral to the talus. And all of these are potentially amenable to a percutaneous technique. And depending on the fracture patterns, sometimes the screw construct and the position of the screws will change accordingly. As you start to study these and look at the CTs, you'll start to recognize different patterns. And the pathoanatomy of these have actually been studied by Corey Collins and others. So if you look at the CT anatomy, what we see is that it's not simply a malreduction in the sagittal plane, but often that there's also some adduction and valgus deformity of that tongue fragment. So then you may start to look at those fracture patterns and get a little bit fancy and recognize that perhaps the Chance pin vector isn't going to be purely from posterior to anterior, but you may actually come in a bit more lateral and end a bit more medial, so that as you affect that correction of the deformity, you're also correcting that valgus and adduction deformity at the same time. This has also been shown to be beneficial in those high-risk patients. So the diabetic smoker that you might otherwise just say, look, there's no way we're going to do an open reduction on this patient. If they have a fracture pattern that is amenable to a percutaneous technique, a couple of studies here have shown that they've had very acceptable rates of complications. So this study, again, small numbers, only 17 patients, but no wound complications. Slightly larger study looking at closed reduction and screw fixation in high-risk patients with open fractures, smokers, and those with substance abuse, and compared to open treatment in healthy patients with none of these comorbidities, no difference in complications. So it allows you to start to stretch the envelope, particularly if you see significant deformity in those high-risk patients that you're concerned about an open treatment. And then here you can see this is extending the indications even further. And this is Larry Marsh at Iowa. And this takes it beyond what I would tackle, but he's doing some 3As, ABs, ACs, and even some type 4s percutaneously, and again, reporting excellent outcomes. So you can take and stretch the indications of this with some attention to the imaging and through some small incisions, and turn a very deformed calcaneus into one that's very manageable with relatively safe risk profile. So looking back in preparation for this talk, if I look back at my recent practice, I fix about 15 calcaneus fractures a year. So not a huge number, but I think a reasonable volume. And I don't fix them all. There's still a number that I treat non-operatively. But looking at the last 5 years of my practice, about 46% of them managed percutaneously. And as I become more comfortable and facile with it, I have started to stretch the indications again to some more challenging fracture patterns and some higher risk patients. And so far have been very pleased with the results. I don't kid myself that the reductions are perfect. These are all done fluoroscopically, but I will take a fracture that I think has an operative indication and with a very safe technique, bring it to one that's with very minimal deformity, minimal articular step that I think is very amenable then to early range of motion. And if they go on to have troubles down the road, you've set them up for a very routine subtalar fusion. Tips starting out, if you're going to apply this technique before you get stuck with that urgent fracture in the middle of the night where you need to try to figure this out for the first time, I would start with some simple fracture patterns in patients that have good skin condition so that you have time to practice this technique and then to adopt some of the nuances as you move forward and apply it to some more challenging fractures. Earlier is easier. It's much easier to get that fragment to move within the first 3 to 5 days. So don't leave this for 2 weeks like you normally would for a potentially open technique where you're waiting for the soft tissue swelling to resolve. I'll do this if there's blisters. I'm not really worried about the soft tissue envelope because it's all percutaneous. And the earlier you fix these, the easier it is to get the reduction. There is a learning curve. So again, start simple, be patient with it, set yourself up with plenty of time. But I think as you look at this and apply it to your practice, you'll find it to be a very useful technique. So in summary, beware the skin complications, particularly in those tongue-type fractures. And again, this is about 20% of the cases that you'll see. Consider percutaneous reduction and fixation in your practice. It's a simple technique, few complications, and I think a relatively manageable complication profile, even in those high-risk patients, the diabetics and smokers. Again, start simple and build from there. Thanks very much.
Thanks, Dr. Cole. Great summary for, and actually encouraging a lot of people to go ahead with trying the percutaneous technique. So last but not the least, Dr. Canada going to talk to us about elderly ankle fracture.
I'm trying to get my screen up.
Do you have, can you see share screen? You got share screen at the bottom. I think you just got the wrong screen, probably shared. Try unsharing again, maybe.
Yeah, it should work.
Always seems like they put the button in a different place each time.
Okay, I know it says I'm screen sharing, but it's not letting, okay, screen, okay. Basic, advanced, it's not letting me pull up my,
Can you try maybe end sharing and then resharing again?
Okay, I'll stop share and then I'll start again. Yes.
There, there.
You got it?
Yeah.
All right. Well, thank you. First I'm so in awe of the COTS and all the research that you do. I've learned so much, and thanks for the great talks ahead of me, and thanks for this invitation. Tonight, I am going to talk about continuing the trend that Dr. Cole's just talked about, less is more, and percutaneous fixation. I'm going to talk about the elderly ankle fracture, where less really is more. Here's my disclosures and also my social media accounts. I've been trying to advertise this. So here we are. Consider yourself lucky. You're on call for the Victoria Day weekend. You hit the jackpot. You have a fracture in a frail elderly patient. And let's make the most of it. So here's a typical patient history. As I was looking at this talk, I did a little bit of research on the patients 65 and older. Florida, we're one of the grayest states. Close to 20% of our population is over 65. In Canada, you're about 15.6%. So we still have about 5% more. And my goodness, they all seem to find their way to the trauma center. The patient is an 83-year-old female. She uses a walker when she's out of the house. Has, rheumatoid arthritis, hypertension, coronary artery disease, an occasional drink. We do find these elderly patients do like happy hour in Florida. She gets up in the middle of the night and has a fib. What is a fib? It's the fall in the bathroom. That is the number one cause, not only of ankle fractures, but also hip fractures. They all fall going to the bathroom. So what I call elderly fractures, especially to the ankle, it's often the elderly fracture trifecta. We have poor skin and bone, compromised healing capacity, which we already have because of their age, and impaired mobility. There it is, the elderly fracture trifecta. So let's start with the poor skin. The facts. As you age, your skin becomes slack. You lose the elastin. The skin, you can see, becomes more transparent. The epidermis gets quite thin. The skin becomes more fragile. That's because the layer between the epidermis and dermis is flattened and becomes much, much more fragile. Skin becomes more easily bruised. There's thinner blood vessel walls. Poor skin, those are the facts. And poor skin and fractures, it is not fiction. These are just two examples of elderly ankle fractures I've taken care of recently. So the key is you can't change what you're given. So you got to come up with some good solutions. and you saw the skin I showed you. My goal is to avoid further insult, carefully handle the tissues using indirect reduction techniques. I mean, just even with elderly distal radius fractures, you know you can tear their skin when you are reducing. You must be very careful and caution people. One technique that I've also found is when I'm doing some manipulation, even when in surgery, I take some of the surgical lubricant and use it on their skin so their skin is easier to manipulate without shearing off. That's a technique I found very helpful when needing to perform some manipulation techniques. And I plan for fixation and realize your plans may change. The winner always with poor skin in the elderly is less is more. What about the bone? This is just a picture of a hip fracture. You can see the bone is poor. Osteoclast and osteoblast activity changes as you age, as you get older. The bones lose calcium and other minerals. And there's hormonal changes present, especially in women who are postmenopausal. So the bone is quite poor. And it's not fiction. It's true. You lose your cortical thickness, the microarchitecture changes. Very difficult to obtain screw purchase and difficult to obtain rigid fixation. You're not going to be having great success trying to compress fractures with this poor bone. It's eggshell quality. So my solution, as I said, less is more. Let's look at a few cases. So this is the example you saw. And I really question sometimes, is this a skin tear versus an open fracture in some of these situations? This was a trimalleolar ankle fracture with a very small posterior malleolus piece. You can see what her skin was. And she was ambulatory despite the skin looking like that. So I decided to use the least amount of fixation to keep that ankle stable. And I used this diamond pin. Another example for fixation, and we'll talk about some of the literature and all that. I'll go back to this diamond pin. This diamond pin, there is a case series reported way back in 2000. They had 7 cases, so not a lot. Everyone healed. There were no skin complications and no hardware failures. The patients did have osteoarthritis when they in follow-up. But again, at this age, they already have arthritis. So this is something I found to be quite helpful with the elderly population. And it is done more than once a year in my practice with these patients. Let's look at another one. This is a typical pattern I always see. The skin is always, it's open medially all the time. It always comes out, it's all just skin and bones there. And you can see, and I'm not just showing all the views where I just want to concentrate on some tips for fixation, but you can see the fibula fracture extends up. My solution is limited fixation. I use a headless compression screw and and I don't just put in the elderly. I always use a small plate, a 2-hole plate, to be like a washer, just because even the screws would pull through their skin, would pull through. So I don't want further insult. So this is something I use regularly. I've had a few this year already, and it's only May. Using this type of fixation. I splint them and I change their splint looking for any skin changes, and then I cast them and go and let it heal and then go from there. So it minimizes any complications. They already have compromised soft tissue, as you can see from many of the examples I showed you. And also that small little medial malleolar fragment, again, it gave stability. A single screw is enough because I am stabilizing it with a splint and then a cast. They aren't going to walk, but I am not having wound complications, and these all heal. They aren't falling apart with close follow-up and regular cast changes. Again, here's that typical pattern. So this is a lady who's on chronic oxygen and had this ankle fracture. Actually, it was bilateral fractures. The same thing was done for both. And her bone is so poor. I mean, I just wanted you to see this. So what I did for this is just, I really couldn't do much more. I put in a screw and Kirschner wires, which were left outside. And then outside of the skin, those were removed at 6 weeks. She was splinted and casted and only could do transfers, but no skin complications, and it healed. It's a win for the patient and a win for me not having to go back and do anything in bone that's butter and skin that's terrible. Here's another example. This is an ankle fracture in a 70-year-old lady. So, possibly on the lower end of the spectrum, more a younger patient. She didn't have the best physiology, and she was in the intensive care unit with multiple medical issues. So this is what I did for her. Chad talked about earlier, it's not, the reduction, it's not perfect, but I restored the anatomic parameters. If you go back, I restored the anatomy. I kept her stable. And in the end, this is several months later, her weight-bearing film. She did fine and did not have complications. And again, minimal cost also. Less is more. What about this? This is a 69-year-old. So she counts as elderly because she's over 65. And she has this posterior malleolar fragment, which really is vertically unstable. What am I going to do? Well, here's her skin. You can see what her skin looks like. And this is her in the operating room. And I elected to only, you can see her skin. I wanted to take care of the vertically unstable fragment, and I went prone and posterior. I did not fix the malleolus, the lateral malleolus, more hardware and thin skin, which was bruised. I splinted her and then casted her, and she's doing fine. She actually works and has returned to work. So again, I chose a prone posterior approach, avoiding a lot of the compromised skin. And in this case, less is more. Something I always advise in the elderly, think about it like a diabetic ankle fracture. You put extra screws across. This is not your syndesmosis screw. These are screws to help with fixation, assist with fixation in stabilizing the ankle joint and in the tendency to shift medially. And you can see more screws, the better. So fibular screws across from the fibula into the tibia, not only low, but also higher. Make sure you aim posterior to anterior and check your lateral carefully. But again, more points of fixation. Treat these fractures like a diabetic ankle fracture. I don't let them weight bear. The young ankle fracture, I followed your study. I let everyone weight bear that doesn't have a syndesmosis injury. They're weight bearing immediately after surgery. In all of these elderly ankle fractures, I put them in a splint and then a cast. I follow them frequently because, again, they have poor skin. So it helps. In summary, I want you to think about considering the patient, many uncontrolled variables. I showed you terrible skin. Shared decision-making with whoever is going to take care of them. Not everyone can go home after these fractures, and you have to work on that with their family. And in the past year with COVID, that's been a big, big decision that we have to make together as a family, because they aren't going to pass the physical therapy. They aren't going to pass their physiotherapy and be able to go home. And that means they go to a facility where no one can see them. So that, you have to think about it. So in many of these cases, shared decision-making is really important, more so in the pandemic. I limit their weight bearing for this short period. 3 months is nothing in the long term of the life that they've lived, and it's better than long-term skin and bone problems. Very important. And in case you think these are my cases earlier this week. Here is a elderly diabetic. He has a total knee in place, open ankle fracture. That was his skin. That's after the washout and the closure. And his skin was so bad that I just wanted to show you sometimes, and this isn't the first time it's happened, I take a hemostat where I was going to put on the external fixator in this gentleman because I wasn't going to put any fixation on the inside in this trimalleolar ankle fracture. When I just put the hemostat to find his bone, as he was 194 kilograms, it just cut right through his skin. This is just me putting the hemostat to his skin. It cut right through. So that's what I said. You're dealt with the elderly fractured trifecta: poor skin, poor bone, poor healing. But on top of that, while I was in the operating room doing this is the consult. Another one, a 96-year-old female. They said, oh, at least she's on no blood thinners. And you can see she has diabetes. She's already had amputations. So it's a regular problem that I deal with. The elderly ankle fracture, often open. I encourage you to go with less is more. And I'd like to thank you for this opportunity. And I do spend my summers 2 weeks in Maine, so right below the Canadian border. There I am with my family in Maine. So thank you for this opportunity.
Thanks, Dr. Canada, for a great talk. I agree, less is more for elderly fragility fractures. In general, we are just a little bit over time. I hope it's okay with everyone. And it's understandable if anyone need to leave or sign up at 8 o'clock. So let's go back to the group. Anybody have any question for Dr. Schneider, Dr. Canada, and Dr. Cole?
Please feel free to throw questions into the chat and I'll keep an eye on them.
Okay, meanwhile, yeah. Sorry, go ahead, Brian.
No, so I said, but I don't have any yet, Jamal, so.
Okay, so I have a question actually to start with Brasm. So nice talk, nice summary for the study, but question about why the group decided for 2 screws, tricortical screws than 1 screw or 2 or quadrilateral screws?
Yeah, that's an excellent question. I think you highlight with the nature of your question just some of the unanswered things and the variability in treating these injuries for sure. And so the reason for the small fragment screws, we went 2 small fragment screws tricortically. There have been small series, and they are very small, that have compared tricortical, quadricortical, 2 screws, 1 screw. Really nothing has come out sort of in favor of one over the other. And so this seemed to be in our group the most standard of care across Canada for the 2 small fragment screws, tricortically placed. And then we wanted to compare that. And it's important to note that it was a knotless dynamic stabilization with a tightrope.
Okay. There was a recent actually RCT from Norway where they actually compare 1 tricortical screw to the tightrope, knotless tightrope, and they find no difference. And they have a follow-up for 2 years with even CT scan at 3 months, I think 6 months, 1 year, 2 years.
Yeah, it's an excellent question. And I think I'm trying to remember exactly the number of patients that they had in that particular study.
I think 40, 42 in each. Yeah.
Yeah. So unfortunately, a bit on the small side. And it wasn't a study that was captured in the series of meta-analyses that came out over the last couple of years. There were 3 meta-analyses that compared dynamic versus rigid stabilization. And, really kind of looking at that overall picture, certainly those 3 meta-analyses agreed lower infection rates, reoperation rates, and importantly, malreduction rates with the use of a dynamic stabilization device. So I like that we're continuing to try to push the envelope for posterior malleolus fixation, single screw versus dynamic, but still some to be learned. But I think certainly the trend is falling in favor of dynamic stabilization of this joint injury.
There is one question in the chat and one Dan
Axelrod has his hand raised, so we'll go with that, and then we'll get to Julian's question.
Guys, it was a great talk. I just have a question, I guess, for Prism and or for anyone who wishes to answer it. It's again about syndesmotic fixation. So there was a study in Bone and Joint Journal. Dr. Kubik and Natalie Rollick, who are Calgary, I think, graduates, published that there is asymmetry in the syndesmosis. So they compared native to like uninjured sides, and it was 35 or so percent what would be considered malreduced, just comparing two uninjured ankles. How do you think that fits in with your study? And then do you think that that is a reason to further push for dynamic CT scans? Because it's not the static view that you care about, it's more the dynamic relationship.
Thanks very much for that question, because I think this is a really exciting area that we're certainly learning a lot about. And we've seen very similar differences between patients. And it's really interesting if you look side to side how variable even our planar imaging is of the syndesmotic complex. And so I think that's one of the really nice advantages of 4D CT. It allows us to look at actual physiologic motion over time. And we know that there's so much rotation and translation. It's actually quite remarkable of a normal joint. So trying to reconstruct that is really the challenge. The one thing I would say is that if you're using the contralateral limb as sort of a template, so to speak, we really have learned that you have to control for the foot position. So quite often we'll vary the foot position between the two limbs when you're trying to use that information intraoperatively. So I think lots to be learned there.
A quick question. Prism, you may have answered it already, and if so, because I was late to joining. But are you routinely using it now then, Tightrope?
Yeah, I would say two things. Number one, we're certainly using dynamic stabilization much more commonly for sure. And the other trend that's really becoming apparent is actually fixation of posterior malleolar fractures in an attempt to stabilize the syndesmosis. So we've actually now begun using dynamic CT analysis for posterior malleolus fixation as well. So hopefully we can report on some of that soon, because I also think that's a really interesting component to this puzzle.
So I have two questions, and I think both Chad and Lisa could weigh in on it too, Prism. But my question is, all things being equal, there was no price difference at all. What would you use? And so, because we were on a meeting today and everybody saw, oh, it's too expensive. So my question is, if there was price was not an issue, what would you use? And secondly, what was my second question? Oh, that's crazy. It's my early onset dementia setting. What's that?
It'll come back to you.
Yeah, and who would be your ideal patient? That's my second question. But I'd be interested in what Chad and Lisa had to say too after you, Prism. Sorry to.
No, that's great. Maybe I'll tackle cost really quickly, and then certainly we really did try to address this in the COTS paper, so it is worth a quick look, because there has been a cost analysis done by other authors that have looked at. Really, it becomes cost neutral because such high syndesmotic screw removal rates, ironically. And so unless your screw removal rate is less than about 10%, the cost is really less of a factor than it should be. But it's certainly an argument made all the time. I would argue the cost of a malreduction is far more expensive. So for me, cost neutral or not, I'm really drinking the Kool-Aid on seeing better functional outcomes with dynamic stabilization.
So I agree with dynamic stabilization and you asked for the patient. So Brad, the elderly patient is not going to get anything dynamic. I believe
so minimal.
A couple of things. I think the ideal patient would be 50 or younger physiologically, or maybe 60 or younger, depending on their physiologic age. Because as you age, you have to think about the bone and the healing potential. And I've never had to take out, when I think about the 20 years that I've been in practice, the syndesmosis screws that you do have to take out, people feel that they're tight or loss of motion. And it's often the younger patients that I end up taking the screws out. So again, that's why I'd use dynamic fixation hands down in the 50 and under population, because I believe even after 50, even though we want to say, the 50-year-old is young, there's bone issues that I would like more rigid fixation.
Yeah. That's okay. So, Chad, we'll move on. There is a question for you in the chat, Dr. Chaplot. Do you sometimes combine perc fixation with small open reduction for any of the non-tongues?
I haven't been. There's certainly some publications that look at either using a sinus tarsi approach with this, or some people even describe subtalar arthroscopy. For me, this has been purely fluoroscopic. If I feel that I need to do a more open approach, one of my colleagues does plating with a sinus tarsi approach, I would pass them along to him. I have been underwhelmed with my ability to see really well into the subtalar joint through a sinus tarsi approach, at least in my hands, because with that fracture, I find it difficult to distract it enough to see. So the few times that I've tried that, I haven't been that impressed with that it changed much beyond what I could see fluoroscopically. But certainly that's described, and as I said, arthroscopic techniques have been described as well.
Do you need it to, in your perc technique, which looked really good? Do you need to address the perineals at all, or do you find with the tongues you're not needing to get in there as much, or?
Typically not. And if you address them early, Brad, I think it's a lot easier to get the reduction. And again, I don't kid myself that they're perfect. I don't do post-op CTs on them. I certainly will accept that there's probably still some articular malreduction, some increased hindfoot width that I could better address with an open technique. But these are for those fracture patterns that are friendly to a percutaneous technique, or for those high-risk patients that I typically wouldn't open. That lateral to medial screw, I think you need to be careful around the perineals and around the sural nerves, so a good blunt technique there. But typically haven't had the issues with the perineal tendinitis and the problems that you sometimes see with plate placement.
Mm-hmm.
The other thing I think that's most impressive with these is they heal much more quickly. They'll often come in, they've already been weight bearing at 6 weeks, because the calcaneus population is not unique. They present with some certain challenges that you guys have all seen in your trauma practices, but they'll often present weight bearing, and it's surprising that their range of motion in their hindfoot is much better than those that I treat operatively with like an open reduction. I think just they have less scar tissue formation and less stiffness.
Sorry, I have a question in the same regard. So how do you deal with an sagittal split in the anterior process? Because your two screws anchoring it into your process, but a lot of time we have a sagittal split into that anterior process. So that anchor is actually not stable.
So if you have those, and again, if you're starting out, I would start with a more simple fracture pattern where you don't have a lot of anterior process comminution, but you can start by stabilizing that sagittal split with a lateral to medial screw, similar to that one that goes into the sinus tarsi. And then you've got a post upon which to rest those two screws that go from posterior to anterior. So again, you have to individualize this to the fracture. And as I said, I'd start simple. And then as you get comfortable with the technique, you can start to adapt it to some more challenging fracture patterns. But great question.
Yeah.
Just a question. I was just going to say, just to kind of tie all the talks together a little bit and get something from all the panelists. I mean, how important for each one of these sort of group of injuries, I'd say like the younger kind of high functioning ankle fracture and an elderly ankle fracture and the calc fracture, considering some MIPO techniques, and how important is that discussion with the patient before you're going on and deciding, and what the timelines look like for you guys? Is that, looking for like, are you accepting maybe say a 1 week following the injury so you can discuss with this patient and get them and get their understanding, or are you just sort of picking the technique you think is going to work best for that person based on their injury x-rays?
I guess I'll start, for all these patients, you can see, and I can't begin to say, as you saw my Tuesday afternoon was spent with 2 more elderly patients with ankle fractures. I get these all the time. I try and operate on them right away because most of them are open or their skin is compromised. And I do the least amount of fixation. And I will, and what I showed you, it's not to make, as Chad said, it's not perfect. That's not the ultimate function in a patient that's 75 and not as highly functional. But it is, we want to restore alignment and give them the ability to function, which they can do after this because they didn't have skin complications. And that's, or hardware failures. The hardware that I put in, all of these, I take this diamond pin out. I try to make it last 10 to 12 weeks just to give stability. I take the K-wires out as they get loose when they come into clinic. If they start coming out when the cast falls off, then I'm going to take it out. I try to get as much time as I can. And I do talk about it with them. Most of the time, all these elderly ankle fractures are operated on right away. Their swelling is different than the high energy young patient because there is really there's not a lot of muscle there to swell and not a lot of energy that comes with these fractures.
Herman, I think your question is actually really interesting. And I had to pause for a moment because I'm thinking of the 3 populations and their expectations are really quite different. It's interesting. So like Lisa said, it's independence for those folks. You just have to keep them independent. They don't want to lose that. For my perspective, for the calcaneus fractures, I'm just trying to avoid complications because they're such a challenging group, to be honest. As you mentioned, Chad, they walk, they leave before they should. They certainly don't elevate and take care of their swelling. So they are a challenging group of patients. And so their expectations are almost secondary to my expectation to avoid a complication. And then the ankle fractures, they tend to actually, or sort of, I guess if we think about the younger, maybe more active ankle fracture with a syndesmotic injury, these folks want to get back to doing the stuff they love as quickly as possible. And so again, that's where my slant comes towards, dynamic stabilization of a joint, get them going as soon as absolutely possible. So I think it's a really neat question to tie everything together.
I think for mine, at least with the calcaneus fractures, the ones with skin at risk, maybe there's not much discussion to be had. They're forced into an operative line of treatment. For the others, the displaced intra-articular ones, particularly in the patients that are smokers and that have risk factors, then obviously I'll have a lengthy discussion with them of operative versus non-operative. And, I think you try to inform the patient of the risks and involve them in the decision. Sometimes they're looking for you or to you for guidance as to what you think they should have done. So I'll present them with the options and typically looking at that fracture pattern, looking at the patient and their risk factors, I'll guide them towards what I think would be the best treatment. Often they'll have the final word. But with the percutaneous technique, it certainly has led me probably to be more aggressive in offering surgical techniques because the risk profile is much lower. And some fractures that I historically would not have treated with open techniques, certainly I'm more inclined to treat percutaneously. But ultimately, you involve the patient, give them the last choice.
I know. Herman, do you have time for other questions or?
Well, if there's any other burning questions, we can certainly hear them. I don't want to keep everybody too long. I want to be respectful of everybody's time. But just maybe we can see if anybody in the audience has anything else left that's burning a hole. Or I think, thanks for answering, I guess, kind of a little bit of a obtuse question, but I think it just highlights the concept of, although the technique and the concepts of minimally invasive techniques in anatomic reductions is principles that we try to hang our treatment decisions on. A lot of it is just so individual based on these groups. And I think it highlights, the challenges in caring for them, highlights the challenges in researching these injuries. And, RCTs are great, but sometimes they're challenging to do. And maybe with all of those questions you highlighted, President, at the end of your talk, maybe we need to find a different strategy. And certainly when we think about other patient populations, elderly ones and calcaneus patients who have lots of different options as well, I think maybe we need to adjust our research a little bit in terms of how we try to find these answers. So I don't see any other questions, and I want to respect everybody's time. Thank you so much to the moderators for running the discussion and the speakers for some great talks and discussion. discussion items today. Thank you so much for sharing your time and your expertise with us. And this has been a really exciting initiative to kind of watch morph, and we have a few more morph coming up. And then I just want to remind you guys that we have our session next week for cases looking at upper extremity, foot and ankle and open fractures. I think we saw a few of our panelists for next week on the chat and the webinar tonight. Dr. Buckley will be one of our panelists, Dr. Brad Muhlenkamp from Ottawa, Dr. Dominic Rouleau, and Dr. Julie Adams. So we have an interesting group of panelists to talk about some interesting cases next week. So feel free to join us for that. And thank you again, everybody, for